So our recruitment process was similar for this study. We did have a larger sample. We had 557 residents living in 48 houses. Again, we recruited our houses first from the Sober Living Network, and then we recruited residents from those houses. Our eligibility criteria were a little bit different. We only required a history of drug or alcohol problems rather than AUD. But we again required that folks had moved into the house in the past 30 days, so that these would be new residents. We collected longitudinal data from these folks across 3 time points. And our outcomes here are percent days abstinent and psychiatric symptoms as measured by the PDSQ. To look at the social environment, we again used the REIS. To look at architecture, we used the RAS, the Recovery Home Architecture Scale, which I'll go over in more detail. We looked at 8 different measures of neighborhood level conditions, and we tested associations in longitudinal mixed effect models. We first looked at exposures separately, so we had a whole bunch of separate regression models in which we were testing individually associations between each exposure and outcome. And then whatever was significant at the p less than 0.05 level, we included in our final model, which is what I will present to you. So the Recovery Home Architecture Scale, the RAS, this was also developed by Doug Polson in collaboration with Fried Whitman. The RAS has 6 subscales that are listed on the far side. The second column is the number of items that are in each subscale, and then we have the average and the ranges for the scores. So for each subscale, and I apologize if you can't read from the back, so first starting off with house maintenance, this assesses the overall appearance of the interior and exterior of the house and includes whether maintenance equipment is provided. Safety and security assesses the security of the premises. Are doors locked after hours? Is lighting appropriate? Sociability. So this assesses the spatial layout in terms of how it facilitates social interactions. So is there a room that can accommodate all residents, for example? Personal and residence identity. So this is the extent to which rooms can be personalized in the house, and also whether the residence itself distinguishes itself as a recovery residence. So whether there's signs or recovery messages or plaques or things like that. Furnishings. So this rates furnitures and fixtures, including comfort, appearance, and durability. And finally, outdoor areas rates the privacy, maintenance, feel, and suitability for recreation outside. In terms of the neighborhood level exposures, we looked at the walk score, the bike score, and the transit score. So how walkable is the neighborhood? Is there public transit nearby? We looked at proximity to inpatient and outpatient treatment for mental health and also for substance use. We looked at the availability of 12-step groups within 1 mile, and we looked at alcohol outlet density within 1 mile. So our results from this multi-level sample. So these are our outcomes over time. The solid line is percent days abstinent, and the dashed line is psychiatric symptoms. Both of these are moving in the direction that we want them to move over the course of the study. So we see that PDA, or percent days abstinent, starts at 71%, but goes up to 84% after a year. And the average number of psychiatric symptoms that are reported starts at 28, but goes down to 15 by the end of the study. These are the results from our final longitudinal mixed effects model. I want us to focus on what's in the red box, if you are able to see it. These are our main exposures of interest. And again, this model includes all of these together in one model. If there's a dashed line where you would expect to see an estimate, that's because it was not significant at the p less than 0.05 level in the separate model. So what we're seeing here to interpret these results, let's start off with the RAS house maintenance. So what we found is that higher scores on house maintenance were related to significantly lower scores or significantly fewer psychiatric symptoms reported. Personal and residence identity, so greater scores on this were actually related to significantly more psychiatric symptoms. The walk score, more walkability was related to lower percent days abstinent and more psychiatric symptoms. The bike score was similarly related to lower percent days abstinence. More self-help groups within 1 mile were related to significantly more percent days abstinence, so that's hypothesized direction, and similarly more alcohol outlets within 1 mile was related to significantly less percent days abstinence. So again, in the hypothesized direction. So what we found here was neighborhood availability of self-help groups and fewer alcohol outlets seem to be protective for individuals living in sober living houses. House level factors related to better maintenance also seem protective in terms of psych symptoms. We were somewhat surprised to see that walkability was related to worse outcomes. But when we looked into this more closely, we did see walkability is actually correlated with density of liquor stores. So if you are in a place that's walkable and has a lot of liquor stores, you might be exposed more to things that might trigger relapse. And Amy has found that sober living houses are often located in neighborhoods that are both walkable and have a lot of alcohol outlets. And I'm sorry, I was using alcohol outlets and liquor stores interchangeably. Alcohol outlets are anywhere that sell alcohol. So some conclusions from these analyses, we think that there are implications for providers as well as operators as well as residents. So providers who are thinking about where they can open houses should consider our neighborhood level effects. Folks who are operating sober living houses could consider things like house maintenance and how that might improve outcomes among residents. And folks who are looking for a house to live on their own, they can also think about these results and how they might want to think about the neighborhoods and house level factors and how that might impact their outcomes. So we published this last year in JSAD. Happy to share with anyone who's interested. I believe I'm going to pause again for questions on this study. Yes.
I think just, I don't know, like it's hard to think about like what to do about the walking and biking scores with the sort of decreased abstinence. Like it seems like it would depend on whether the philosophy is that, while people are in recovery, they should sort of be living their normal life, but in a house that is kind of conducive to sobriety and like, I don't know, like I think versus like keeping them locked away somewhere very far from anything that resembles real life or liquor stores, I guess. I mean, are you guys in a position to make recommendations? And I guess do you have ideas about what best case scenario might be as far as solution and like how to deal with issues like that, like the walkable accessibility? It does seem like, especially people in cars, they kind of need to be able to access their jobs and everything else.
Right. Yeah. So you asked a couple of different questions. It's okay. So maybe I'll just focus on the easier part. So we do, offering recommendations is a little too strong. I think I wouldn't say we offer recommendations, but what we do is we have focus groups with house managers and operators as study findings come in. We share those with the operators. We talk about what do you think? What would you do with this? What would you like us to look at next? So we do involve them and go over findings and hear about their thoughts on them.
I guess, have you asked them about that aspect, like with the closeness and proximity?
Um, we, I think we have asked them and we've talked to them about it. And yeah, it is a difficult question to answer.
Sure, I mean, it's just a trade-off.
Yeah. Thank you. Any other questions about our multi-level study? Yes.
Like, how to assess or whether your data would have any ability to answer this. So I'm thinking about a situation where, like, maybe because of a higher availability of alcohol, one person in the house, like relapses or like brings alcohol into the house, and then the sort of fear and knock-on effects that that can have, giving inside there.
So that is something that does happen in houses. There are folks who relapse. I mean, that's very common. Often there is no one answer for how an individual is dealt with. I mean, these do vary from house to house. It varies also on what kind of history this person has. Is it the first time that they did it? So I believe that depending on the house, they will react accordingly on a case-by-case basis. That being said, these are abstinence-based environments, and often the rule is if you are using, you are evicted. And there are often not second chances. Other questions?
Sorry, one more.
No, no.
So when looking at like a level 4 house, would that be similar to like residential rehabilitation, since they do offer the treatment, or are those distinct from each other?
They're technically not treatment, but they are very much like treatment. Yes. So, and thinking about your earlier question too, I think Liz Mahoney might be on virtually, and she did do the focus groups with the house managers, and so she might have some insight into your question about walkability. Liz, I hope you're listening. So maybe when we're done, Liz can jump on. Yes.
Curious about the LA specific context as you're thinking about these environmental pieces and sort of how much you think what you found generalizes to other areas, but you also mentioned that a lot of sober living houses are in California anyways. Are they mostly in Southern California? Like is this really the environment that they exist, so it is the full picture, or could you speak a little bit to that?
Yeah, thank you. That's a great question. So, right, you're correct. These houses are most popular in California, but it's also true. I mean, LA is very different than San Francisco. So that is certainly something that we think about in terms of generalizing. These are LA findings. Yes.
On the question of walkability and also being LA, is there also a correlation with walkability and maybe space, and that would be a separate or an easy place to drink? And I'm thinking, like, to her point of if you're more likely to be caught out if you bring alcohol home, or back to, or depending on the type of organization, level 1 to 4 there is. If I'm living in a highly walkable place where it's very easy to go to a park or something, then does walkability correlate to access to those spaces where it's easy to do something quickly, privately, no one will find out, put my mouth out, and I can like that, versus if I'm in a quote less walkable place, and this is a very walkable area, that access also is missing for an easy place to hide to do something.
You're probably onto something. I don't know how we would look at that. I don't know how we would measure how many places there are to hide near a house, but it,
So a park
Sure.
that's kind of known
Yeah.
for, you know, and I'm thinking like even living in places like Albuquerque, New Mexico, where you, these areas, these parks, or, you know, good access points if you were looking to go drinking or you find needles afterwards, versus other areas, even if walkable, there wasn't, say, maybe a park access or kind of a quieter spot,
yeah.
as that might be safe also.
Yeah, so looking at public spaces around, that's a great idea. That's not something that we have looked at. Any other questions about the neighborhood study? Oh, wow. Time is flying. Okay, so our last study, assessing the role of cannabis in sober living houses. So these are secondary analyses using data from the last two studies that I just talked about. So this so far has not been funded. This is a subject that is interesting to me, and so that I have started looking into it based on the data that we have available. So you might be wondering though, why look at cannabis use in sober living houses of all places? So, well, there is some evidence that cannabis is used as a substitute for alcohol and other drugs. Here's a few papers, including one of my own. Results from these papers do conclude that, or these papers conclude that cannabis can be and is being used as a substitute for alcohol or other drugs in these particular samples. So getting a little more details on these papers. Support for cannabis as a substitute for alcohol. So this has been seen in medical cannabis patients, but also among individuals with alcohol use disorders. So a review on cannabis substitution for alcohol that was written by yours truly concluded that cannabis met 6 out of 7, met or partially met 6 out of 7 criteria for substitute medications for alcohol. One of those criteria is that it reduces alcohol use and misuse. There's also support for cannabis as a substitute for other drugs. So this has again been seen among medical cannabis users, but also among community-based samples of people who use drugs. So people who inject drugs, adults in early recovery from opioid or stimulant addiction. There is a high prevalence of reports of cannabis being used as a substitute in these populations. Folks often cite harm reduction benefits as a reason for using cannabis as a substitute, so fewer adverse side effects, less withdrawal potential. And some have even suggested that cannabis could be used as a substitute medication for OUD, for opioid use disorder. So there's the scientific research and there's the messaging that folks have gotten. I think these companies have taken our research and ran with it. So these are billboards mostly from California. This one in the corner here is from Arizona. But these advertisements are making very blatant claims about comparing cannabis and alcohol. So we see hello marijuana, goodbye hangover, hello marijuana, goodbye headache. This one, marijuana, less toxic, less addictive, less scary than alcohol. That one in the bottom corner there, I like especially because there's a Bud Light billboard on one side, and then right next to it, it says, hello, marijuana, goodbye, hangover. And so they're really like putting it in your face, these comparisons of alcohol versus cannabis. It's better for you, it's safer. It's even safer than football. And this is also being done with opioids. So this is not specific to alcohol. This is being done with opioids too. So these companies like Weed Maps are making these blatant comparisons. State that legalized marijuana had 25% fewer opioid-related deaths. So they're really putting it in our faces that cannabis is safer than these other drugs. We live in California. How many folks have heard about the California Sober? Okay, so all the way in Illinois, people are hearing about it. Yeah, so California Sober, what does that mean? This is from our newspaper, the SF Gate in San Francisco. Willie Nelson says he's California Sober. He uses cannabis, but he doesn't do anything else. So that's what Willie Nelson does. This term is also popping up in more reputable publications, like this is from the Cleveland Clinic, a healthcare organization. What is California Sober approach to substance use? An addiction specialist weighs in on the rising trend of semi-sobriety. So there's the scientific research, there's the advertisements that we're seeing. We're interested in recovery residences. So the National Alliance on Recovery Residences had a request from one of their affiliates asking them, what do we do about cannabis in our houses? So NAR came up with this policy guide on medical cannabis, and they state a few things that I'm going to highlight right now. So first, that no affiliate is required to allow cannabis, medical cannabis in the recovery housing. If the residence does decide to permit the use of medical cannabis, they should, these are on the right here, these are recommendations for building the policy if the residence does decide to allow medical cannabis. So for example, only edibles or pills, just no combustible products. Anyone who's using medical cannabis should have a recommendation from a medical practitioner. So there's some rules that they're offering. They also include in their policy guide that medical cannabis is included as an alternate or a substitute for prescription opioids. So the research on cannabis as a substitute, the advertisements that we're seeing in California and I believe elsewhere in the US, as well as these NAR policy guidelines that came out a couple years ago, all of this led to this research question: how is cannabis use related to alcohol and other drug use among sober living house residents? If it's being used effectively as a substitute, we would expect it to be related to less alcohol use, less alcohol problems, less drug use. So you're already familiar with this because our data came from the multi-level study. So 557 participants collected data longitudinally. Here's a map of where the houses are geographically located across Los Angeles. Again, we sampled across quintiles so that we did represent diverse neighborhoods. 1 represents the lowest SES and 5 is the highest SES neighborhoods. So what did we find? In the multi-level sample, we saw that about 1/5 of participants reported past 6-month cannabis use at baseline, and that this remained steady by the end of the study. So the 12-month follow-up, we still had about 1/5 of participants reporting cannabis use in the past 6 months. In longitudinal models, we found that cannabis use was related to significantly worse outcomes across the board. So it's higher odds of alcohol use, more drinking days, higher odds of problems, alcohol problems, more drug use days, that's more non-cannabis drug use days, and higher odds of non-cannabis drug use problems. We replicated this analysis in the helping sample, so among the 205 residents from the helping sample. And things were kind of even worse in that one. So in this sample, it was almost 1/4 that were reporting recent cannabis use. So that's in the past 30 days now, not past 6 months, but past 30 days. And this was related to significantly higher odds of alcohol use, more drinking days, higher odds of alcohol problems, and higher odds of non-cannabis drug problems. So for those who like graphs, here I laid out those odds ratios and incidence ratios visually. So here the blue line on both of these graphs represents no association, null. And we can see a very similar pattern across the two samples, right? Number of drinking days, problems, any drinking, it's almost the same exact pattern in terms of the magnitude of the results and the strength of the associations. Towards the end of our last study, the end of the helping study, we were able to add a question to the survey. Thank you, Liz, for that idea. We asked 47 residents directly, have you ever used marijuana with the purpose of substituting alcohol or another drug that you usually use? Only one person said yes. That was kind of surprising, but also matches what we saw in the longitudinal data, right? In the models, looking at the association between cannabis use and alcohol and other drugs, this does corroborate what we're seeing in those associations. That being said, there were about 2/3 of the folks that we asked that reported ever using cannabis as a substitute. And anecdotally, when we've talked to house managers, it sounds like folks have tried using cannabis as a substitute and just weren't able to do it. So they kept using it at similar rates, similar amounts, and it didn't work as a substitute for them. All of that being said, it's very critical and important to me to acknowledge cannabis use may benefit some people and harm others. So I want to validate the experience of this one person who currently uses cannabis as a substitute. I believe them. I mean, yes, on average, it does not seem to be working as a substitute, but NAR recognizes that an absolute ban on medical cannabis could prevent the appropriate use of cannabis. So yeah, let's remember that cannabis is used for reasons besides recovery. You know, there's health conditions that cannabis can be very helpful for some people. And maybe this one person is using it effectively as a substitute. So I just want us to remember that this person's experience is valid, and this is a tricky problem. So all of that being said, our data do not support that cannabis is used effectively as a substitute for alcohol or other drugs among California sober living house residents, not in our samples. We did publish this a few months ago, so if you're interested, I'm happy to share it with you. And I think I'm ready to summarize all the studies that I've talked about just now. So what factors might impact SUD recovery housing access and effectiveness? So I told you about 4 different studies. I started off with our national study. We saw that rurality seems to be linked to less access of recovery housing. Socioeconomic status seems to be linked to recovery housing access. Distance from federal prisons. It was encouraging to us that we saw that recovery residences do seem to be co-located with state and federal prisons, so perhaps they are in places where folks who need them can get to them. We saw support for the social model in recovery residences, specifically sober living houses. We saw that a strong social environment does influence helping behaviors, recovery-focused helping, and that this does seem to be related to more interpersonal benefits and feelings of peer support from others in the house. In our multi-level study, we found that house factors like maintenance, the physical environment of the house, impacts people's recovery. I don't know if I'm not so surprised about that, but I think that's a really cool result to think about how our physical environment does affect the way we feel. Neighborhood factors, so we saw 12-step meetings, access to that, access to alcohol outlets, Those are other factors at the contextual or neighborhood level that can impact outcomes. And we've just started looking at use of cannabis. So to finish off with some directions for future research, for the NSTAR study, we are starting to look at evidence-based practices. So that's part of our survey of the 838 randomly sampled houses. We've surveyed them about their practices. We're going to be learning more about what's going on in these houses. And eventually we would like to look at how those practices are related to outcomes. One study that I would love to do, but I think I need to collaborate with someone in this room, is to look at how recovery residences versus other types of housing for folks leaving carceral facilities, whether there are differences. Might recovery residences, because of their focus on recovery support, might they be more beneficial for individuals with SUD who are leaving carceral facilities? Like I mentioned, I'm gonna start the mediation analyses, looking at how the social model works in sober living houses. We're also hoping to do a deep dive into policies around cannabis use in sober living houses, because we actually don't really know what the policies are. We also want to do more rigorous analyses of cannabis use in relation to alcohol and other drug use among individuals in recovery. Like I mentioned, the analyses that we did were all secondary analyses. We didn't have the data that I want to look at this question rigorously. We don't have amounts. We don't have the kinds of details that would make that analysis rigorous. I have in recovery in quotes here, absolutely not to mock anybody. It is to recognize that not everyone identifies as in recovery. So we have about like 10% at least of our samples, they don't identify as in recovery. They used to have a problem with drugs. They used to have a problem with alcohol, or they're recovered. So I just want to remind us, while we are working with this population, that it is really important to remember how they identify. I've been saying recovery residents this whole talk. Not everyone identifies that way. So I just want us to remember that. And with that, thank you so much for your attention. I'm happy to take questions.
Thank you so much. This is awesome. I also study cannabis, and I just find that part like especially interesting. And one thing that I kind of thought when I saw your results is that, I think when we first started legalizing cannabis, we kind of thought of it as something people couldn't possibly get addicted to or have issues with. And, like I work with claims data, we're increasingly seeing the ICD code for cannabis use disorder pop up. And also, I feel like there's just more and more evidence as the years pass that pretty much anything that activates reward centers can be addictive or can cause an issue for some people. So I wonder if for your population, like perhaps for them, it's not as easily substitutable because it is still a substance that like is going to be problematic for them, or just is, I don't know, like I just wonder if there's something about that specific subsample that maybe, are a little bit more likely to have like, issues related to like misuse or dependence. And so like that might be why like for people who, aren't addicted to alcohol but use it periodically, like it might be easy for them to substitute cannabis, when in this other group, like they kind of need to be able to draw a firmer line of I don't do these things, or I don't know. It just made me think about that. And so I just wonder what you thought, and also, yeah, anything else connected to that you think about.
Thank you. So we haven't in this study, but other studies have looked at how sober living house residents compare to other samples of individuals with substance use disorders in terms of like treatment utilization or SUD severity. There is some data to suggest that it is a more severe population in terms of the level of their substance use disorder. We also have to remember these are folks who need housing. So it's on top of their substance use disorder. It's a population that needs somewhere to live. So that is a critical factor for us to think about in terms of why this population might be different than others.
Thanks. And then also, just to clarify, like you mentioned that if they consumed alcohol, they would be evicted. Is it the same thing with cannabis? Because if so, like if they don't have a medical cannabis card, they might just be unwilling to admit if they are currently substituting because they don't want to be evicted.
So you are asking the $64,000 question right now. So remember on one of the slides, we had 7% of residences accept folks who use medical cannabis. We are curious about the sober living houses that we have in Los Angeles. We haven't, what I would like to do and what I've proposed to do is survey them in depth to understand what are you doing about cannabis. So that, yeah, it's an open question.
Thank you.
You're welcome.
Thanks so much for your talk. It was really interesting. I agree with you that I was particularly interested in the findings around the physical environment, architecture, upkeep, that it's not surprising, but kind of exciting because it's fairly concrete and comparatively easy thing to change. But I can imagine that the constituents you need on board to think about changing those things might look different, like in terms of funding for those kinds of changes or advocacy around those kinds of changes. So that may be further afield than you've really gotten yet, but I'm curious if you've thought about like who to motivate, how to motivate those kinds of changes as a potential lever for improving outcomes.
So what we're seeing in the qualitative data that so one thing that we're seeing in the qualitative data is how important the house manager is as an example for the residents and how they see themselves as setting an example for the residents, like in terms of helping each other and also just how to be in recovery. So I think that they are really our key, the key folks that we can work with in terms of working on things like maintenance or, you know, items from the REIS, like encouraging people to go to meetings together, involving the residents in decisions that that affect the house. Those are cheap or free things that one could do. And yes, and again, the house manager is really the critical person in facilitating that. Thank you.
We do have some online questions. I'm going to try to get through as many of these as we can. Someone asked if sober housing is only available to U.S. citizens. And then when residents, where do they go after staying at these houses? Is there a transitioning afterwards?
So the houses would take non-US citizens. You just need to be able to pay for it. So these houses are not free. There's rent required. So as long as someone can pay, I don't believe citizenship is an issue. I forgot the second question already. I'm so sorry.
Where do residents go after?
Right. So sometimes they go back to their families. In some houses, we do see some very long time residents. So some do get very comfortable in the sober living house. Some become house managers. So it varies. I mean, and unfortunately, some relapse and end up on the street.
There was a question about if sober living houses are protected by non-disclosure rules. How would a neighbor know about sober living in certain neighborhoods?
If there's a house being built, I think it could be, if there's a new house being built, I mean, word gets around. I know in my own neighborhood, I learned about a sober living house down the street just through the rumor mill of my neighbors. Basically word of mouth, yeah.
Someone was asking, and I think this might be the last question, do facility staff play a part in changing participants' positive behavior and non-substance use behavior?
Absolutely, yes.
Was easy.
Yes, like I mentioned a couple of minutes ago, the sober living house managers are heroes to a lot of people. They wear so many hats. They have so many responsibilities. They're in recovery themselves. They've worked the program, and they've dedicated their lives now to helping other individuals who are suffering.
So really quickly, Liz Mahoney did check in and she did say for the question about percent days abstinence being related to alcohol outlets, one house manager pointed out that we did collect data during COVID. Shelters were closed, so some houses might have people who moved in due to lack of affordable housing. They also pointed out that people were not able to work during this time, so maybe they were tempted by alcohol outlets in the neighborhood. Thanks, Liz.
Thank you, Liz.
And I think that's it. So let's thank our presenter today.
Thank you.